All birds find shelter during rain, but eagles avoid rain by flying above the clouds. Problems are common, but attitudes make the difference, said by Abdul Kalam, the President of India. It means if you will fly above the clouds, there will be no rain there because the rain is below the clouds and not above the clouds. This is the approach in life, and it is said that there is always room at the top. Now, sign and symptoms of shingles. In mouth, shingle appears as 1 to 4 millimeter opaque blisters, vesicles which break down to leave the ulcer as one can see in the mouth. Oral involvement rarely cause osteonecrosis leading to the tooth loss, periodontitis, the gum disease, the pulp calcification, pulp necrosis, periapical lesions, and tooth development anomalies. These all are due to the shingles in the mouth, as one can see here in this diagram. Then it can involve the upper jaw, and one can see the lesions of the upper jaw. These are present at the various parts of the upper jaw, and the lower jaw is involved sometime, and one can see the lesion of the lower jaw also, as it is involving the trigeminal branch, the mandibular nerve, and the other branch of the maxillary nerve, so involving the lower jaw. Sometimes the rare sites are the ulnar nerve involvement, and as one can see, the lesion on the distribution of the ulnar nerve, and these are the rare lesion, but sometime it can be seen also. Now, sign and symptoms sometimes are disseminated shingles or wide rash seen with those with a poor immune function. It is defined as more than 20 skin lesions appear outside either primarily affected dermatome or the dermatome directly adjacent to it. Here, other organs like liver or the brain is also involved, causing the hepatitis or the encephalitis, making the condition very lethal. So here one can see the disseminated shingles that is present on the wider part of the body. Then herpes zoster in pregnancy, 90% of the pregnant women are already immune, so primary infection is rare. Primary infection during pregnancy carries a great risk of severe disease. It do occur in first 20 weeks of a pregnancy, and the 3% chances of the transmission of infection to the fetus, and if that is transmitted, it causes congenital varicella syndrome. There is scarring of the skin, hypoplasia of the limbs of the kid, CNS and the eye defects, and the death in infancy is normally seen. The child does not grow up well. So here one can see the congenital varicella syndrome, the lesion on the different parts of the body and involving the larger area of the body. And here one can see the hypoplasia of the limbs, and these are all because of the congenital varicella syndrome, the transfer of the virus from the mother to the child. Now, this is a different thing. Neonatal varicella, it is vary from the mild disease to a fatal disseminated infection. If rash in the mother occurs more than 1 week before delivery, means sufficient immunity is transferred to the fetus. Give zoster immunoglobulin to the susceptible pregnant woman who had contact with suspected cases of the varicella, or one can give Zoster immunoglobulin to the infant whose mother developed varicella during the last 7 days of the pregnancy or the first 14 days after the delivery. So one can give Zoster immunoglobulin to save the infant from that. So here one can see the neonatal varicella, that is just after the birth. One can have these kind of rashes and one can go for the varicella zoster immunoglobulin, which is VZIG, or a human normal immune globulin that is also given as the protection to the newborn. Now, what are the complications of varicella zoster? Secondary bacterial infection, motor involvement, including weakness, especially in the motor herpes zoster, eye involvement, trigeminal nerve involvement as the herpes ophthalmicus, and post-herpetic neuralgia are the complications. This post-herpetic neuralgia, it is the pain that persists for more than 1 month after the onset of the herpes zoster. It is rarely seen in the people less than of 50 years of age. Pain is lacerating, burning, shooting, stabbing, paroxysmal or electrical current flowing in the body. Allodynia, it is a pain due to a stimulus that does not normally provoke pain, like father touch, which is not usually causing the pain, but if that causes the pain, it is allodynia. Pain can be debilitating and increased throughout the day. Pain has two components. One is the central component and other is the peripheral component. Hyperalgesia, abnormally low sensitivity to the pain, and dysesthesia, pain, pins and needles, and warm-like feeling in the body or the skin. Here is the creation of the god that looks like some animal, buffalo, like, but actually these are the branches of a tree like this, that these look like to be an animal. So one have to praise the creator of the god regarding making the things like this. Now, what is the diagnosis of the shingles or herpes zoster? Number one, history and examination with classical symptom. Electron microscopy, number two. Number three, viral cultures. Number four, serology and the other supporting lab test. And number five is the PCR. First, we are going through history and examination. The classical symptom, signs and symptoms are presented via examination, as very few diseases produce a rash in a dermatomal pattern. I have already told you that nerve dermatome pattern rash is always because of herpes zoster. When the rash is absent, shingles is difficult to diagnose, as most symptoms do occur also in the other conditions. So rash is the one which gives the definite clue of varicella zoster, herpes zoster. Number history and examination continuing. Now do neurological assessment of the affected dermatome by the judging vibration sense possible presence of either or all allodynia, hyperalgesia, and dysesthesia. I have already told you what are these. The excessive pain response to a light feather touching to the skin. Test for the allodynia using the cotton wool balls and the sharp objects. Now, the number two is electron microscopy. That is to examine virus particles from the blisters or the vesical fluid as, as HSV and VZV cannot be differentiated. So do immunofluorescence on the skin scraping to see the varicella zoster virus different from the herpes simplex virus. Number three in diagnosis is virus cultures, that is to isolate virus from the blister fluid. Number four is serology and lab test. Varicella zoster virus have got and produce specific IgM body in the blood seen during active chickenpox or the shingles, not while the virus is dormant. Zank test of the skin lesions that can be done by the dermatologist to have the support of this herpes zoster, and the baseline lab test may be indicated, that is CBC, ESR, blood sugar fasting, etc. Number five is the PCR polymerase chain reaction, lymph collected from a blister for varicella zoster virus, DNA considered the most reliable method of diagnosis. Nested PCR test has high sensitivity, but due to the contamination, it sometimes gives the false positive result. So the latest is the real-time PCR test. These are the most useful, more sensitive than the viral culture. It is as sensitive as the nested PCR with a low risk of contamination as it is seen in the nested PCR. Now, what are the differential diagnoses of the rash which are seen in shingles? That is, herpes simplex virus can produce such rash which is called zosteriform herpes simplex. Then dermatitis herpetiformis, impetigo, skin reaction caused by the contact dermatitis, candidiasis, autoimmune blistering disease, certain drug reaction, and the insect bites. These are all having the similarity with the shingles. So this is zosteriform herpes simplex, seen the massive herpes simplex virus involvement. Then dermatitis herpetiformis, impetigo, a bacterial skin infection, contact dermatitis that also sometimes looks like herpes zoster. And here autoimmune blistering disease and cutaneous candidiasis, these also mimic the shingles. Then drug reaction and the insect bite, these are also having the picture like the shingles or herpes zoster. Now, the pain which one is having in herpes zoster disease, there is differential diagnosis of that is herniated disc, myocardial infarction, acute abdomen, musculoskeletal disorder, pleurisy, migraine headache, temporal arteritis, trigeminal neuralgia, and polymyalgia pain is sometimes mimicking like the pain in shingle. Here is the beauty of an artist who have made the things like that. One can't imagine to have this possible shown in the hands of a beautiful lady, and there is the ship in the background, river and the trees and a bridge. It's just unbelievable. Now, coming to the treatment of the disease, aim to relieve symptoms, reduce the complication. It comprises number one, analgesic, antivirals, and steroids. Number one, analgesic, systemic and topical symptomatic treatment, mostly for the post-herpetic neuralgia for mild to moderate pain, over-the-counter pain medication like non-steroidal anti-inflammatory drugs or the paracetamol can be used. But for the severe pain, need opioid medication like morphine and tramadol. Antidepressants sometimes also help. Topical lotions like calamine on rash or the blister for the soothing effect. Once crusts are there, caps, capsaicin cream, Zoster can be used. Topical lidocaine patch or the gel also reduce the pain if applied on the affected part. Antiviral creams like acyclovir and other are also useful. Giving gabapentin plus antiviral give relief of the post-herpetic neuralgia. Mostly once rash has cleared, post-herpetic neuralgia very rarely seen under the age of 50 year of people. And here it is tramadol. It is non-narcotic analgesia, moderate to severe pain. The dose is 50 to 100 milligram per oral 4 times a day. Use cautiously in the renal failure elderly as it causes constipation, somnolence, vertigo, nausea, and it is habit forming. So that is tramadol 100 milligram tablet. Or one can use gabapentin, which is basically anticonvulsant, used in neuropathic pain and post-herpetic neuralgia, 300 milligram per oral on the day 1, then increase to BID to TID up to the maximum of 1800 milligram can be given to get the relief of pain. Use cautiously in renal failure as it causes somnolence and dizziness, so one should take care while operating the machinery. And lidocaine, 5% topical lidocaine patch, as one can see, 10 centimeter to 14 centimeter, which contains 700 milligram of the lidocaine as 5% is available. Apply 12-hour on, 12-hour off, and increase to 3 patches can be worn same time safely, avoiding the patient allergy to the lidocaine, and do not place over the active lesion or the broken skin. Capsaicin topical cream if lidocaine allergy can be used. And now, number 2, the antiviral oral. Oral antiviral acyclovir is the standard treatment. If given within 72 hours of the appearance of the rash, it can reduce severity and the duration of the disease. Newer drugs, valacyclovir and famciclovir, have superior efficacy, good safety and tolerability as compared to acyclovir. Zoster ophthalmicus treatment is similar to the standard treatment for shingles at other sites. Oral drugs are useful for prevention in HIV and the AIDS, as well as used as therapy in acute phase. In severe cases, one can use intravenous acyclovir. The third option for the treatment is steroid. Corticosteroid, not of much value, but epidural nerve block steroid injection can reduce pain in certain cases. Now, the treatment continuing, acyclovir oral 800 milligram 5 times daily, 4-hourly interval for 7 days is given. Immunocompromised individuals use intravenous acyclovir to avoid complication. It is used. It causes lightheadedness, headache, abdominal pain. It is nephrotoxic, so use carefully in the renal approximated cases. So that is acyclovir tablet, which is available as 400, and some of the products are having 800 milligram tablet. Famciclovir 500 milligram 3 times a day for 7 days is another good option because of 3 times a day dosage, and here these are available as 500 milligram. Then cyclovir. It is given as 1000 milligram or 1 gram 3 times a day for 7 days. It is available as 500 milligram, and again it has got the convenient dosage as compared to acyclovir. Tricyclic antidepressant for the treatment of post-herpetic neuralgia, but it has strong anticholinergic effect. So one can give the triptyline or empramine, and epidural steroid have a modest effect on post-herpetic neuralgia lasting approximately 1 month. So here one can see the epidural steroid injection which can be given at the affected part. Now coming to the prevention, shingles vaccines are available which reduce risk of the shingles by 50 to 90%. Vaccination also decreases rates of the post-herpetic neuralgia, and in shingles its severity is also reduced by the vaccine. Chickenpox vaccine, if given before one gets chickenpox, if primarily infection has occurred, use the shingles vaccine. Zoster and subunit vaccine Shingrix are used. These are live attenuated virus vaccine. It prevents shingles for 3 years. 2 doses of the Shingrix are given to all people in their 70s, not over 80s. It is contraindicated, especially given to the leukemic children, neonates, and the pregnant woman. Shingrix is better tolerated than Zostavax. It also decreases rates of the post-herpetic neuralgia and the severity of the shingles. Contraindication in people with primary or acquired immunodeficiency. For urgent protection, one can give the passive immunization with Zoster immunoglobulin. ZIG is given. If ZIG is not available, use a human natural immunoglobulin HNIG. So these are the vaccine Zostavax, and here is vaccine Shingrix, and here is the varicella zoster immunoglobulin, and here is human normal immune globulin. And that is the end of the lecture. I hope you may have liked this lecture. If you have liked this, please subscribe my channel and just share it with the others. It is very comprehensive lecture. I have included everything possible in this lecture. But still, if you have any question or query, please feel free to contact me. And I am thankful to you to be with me watching my lecture, and please just subscribe my channel